As an epidemiologist or a community physician, so it is important always to have accurate results. When we are performing any epidemiological study, it is important to have accurate result from the studies. But actually, there are some possibilities of error occur in the measurements which we are going to perform or we have already performed. So, as an epidemiologist, always offering efforts or attention to minimize these errors in the assessing of the impact of the association between the outcome of the exposure. So the main objectives of this study is to know what are the sources of the error in the studies, or what are the impact of the this error on our studies, and we are going to explain some examples. So the main sources of error are either random error or systematic error, and we are going to explain what are the differences between these two errors. Random error, where there are variability in human population. That means there is always some error in gathering the information on the exposure or on the outcome and any coverable information. So the greater the random error leads to lower precision in the estimation of the association or the effect. And this random error occur can be reduced by increasing the sample size. The larger the sample size, the lower is the error, and the smaller is the sample size, the more will be the error. So the random error occur when the value of the sample measure, the sample which we are going to estimate or to take, diverge or differ from the population. So our results or our sample with which we are drawn from the population, the result of this sample is diverge or it is away from the population or the true population value. This is usually occur by chance, and the random error causes inaccurate measures of association. Random error can never be completely eliminated since we can study only sample of the population. If we take only one sample, so there will be always there is some random error in choosing this sample. So there are three major sources of random error. First, individual biological variation always occurs and no measurement is perfectly accurate. The individual themselves, when we withdraw a sample or when we take a sample from the population, there is what is called biological variation from one person to another, which cannot be eliminated because this is in the constitution of the individuals themselves. Or it could be sampling error, the defect in the sampling technique, especially if you take a small sample. This will be not representative of the whole population, so it is important to increase the sample size to decrease the random error. So the best way to reduce the sampling error is by increasing the sample size or the study group. Another source of random error is the measurement error. Measurement error which can be reduced by rigid protocols. This is because especially if you take different investigator or different researcher who are going to measure from the sample, from the people involved in the sample size, in the sample people. So it is important to have accurate, and it should have rigid protocols, the same method for measurement, and it should be precise as much as possible. So the investigators need to be, they should be understand the measurement, they should be trained on the method of measurement, and this will decrease the error by measurement. Also, it is possible to decrease the measurement error by using the same technique accurate instrument and a standardized method of measurements in order to decrease the random error. So ideally, laboratories should be able to document accuracy and the precision of their measurement by systematic quality control procedure. So it is important to have a quality control procedure in order to decrease the measurement error. The systematic error, or what is called bias, which occurs in epidemiology when the results differ in a systematic manner from the true values. It cannot be removed by the increasing the sample size. So a study with a small systematic error is said to have high accuracy. The smaller the systematic error or the smaller the bias, the more accurate is the study. And the accuracy is not affected by the sample size. And the possible sources of systematic error is in epidemiology. There are large number of causes or sources of the systematic error we are going to explain. So, bias is a major issue in an epidemiological study design, and if it is overlooked, if we didn't take in consideration the bias, it will lead to incorrect conclusion and decision making. If we didn't take in consideration the bias, so we are going to have wrong conclusion about the association between the risk factor and the outcome. So we have always to have efforts and to eliminate or reduce or at least recognize the bias. So this will decrease in the effect of our accuracy of our study. So if it is not reduced by increasing the sample size. So the bias is defined as a systematic error either in the design of the study or during the conduct of the study, during implementing or conducting the study, or during the analysis of the study that results in mistaking estimate of an exposure effect on the risk of the disease. So it will lead to distortion of the result, or it will give incorrect conclusion. So we should take in consideration to minimize the result of or the effect of the bias during the design of the study, during the conducting of the study, and during the analysis, and we are going to discuss these methods. So bias is an error in measuring or in collecting the information that differs systematically between groups of participants. So the bias can result from the design, conduct, or analysis as we mentioned. Bias will reduce the accuracy or the validity of the estimates or affect the association. So the bias will reduce the accuracy or the validity of the study. And it can lead either to overestimation or underestimation of the true effect of the association between the risk factor and the outcome. So the bias will lead to either underestimation of the association or underestimation or overestimation of the association, and we are going to give examples. Even when we have reduced the random error by increasing the sample size, bias can still affect our result as well as the confounding factors, which we are going to discuss. What are the sources of bias? So the sources of bias, it is either during the study design, such as by the selection, during the selection of the sample. How are we going to select the people for our study? It is important to select people in a proper way that it will not result in bias. Or because there sometimes the bias is due to the subject himself. There is variation in the measurement of the when for example when we measure the blood pressure for the same patient example or the same individual, there is variation in the blood pressure during the morning or during the afternoon, or by there are different measurement while the patient is sitting or lying position, or because of stress. Sometimes the first blood pressure measurement should be not considered. Always we should have repeated measurement of blood pressure in order to confirm whether he have or to have the appropriate or accurate measurement, because the first reading usually the person or the individual have he is anxious or he is afraid or have some problem with the doctor, so he will have high blood pressure. So it is important to measure the blood pressure and different times and the same position and the same day time of the day. With an observer variation, sometimes the observer himself or the examiner himself, the investigator himself, this is called intra-observer variation. Sometimes as an investigator, when he measure, for example, the blood pressure for the individual, if sometimes if he repeats the measurements, he will have different measures. This may be resulted from less concentration, or maybe because he is tired or he is fatigued, so he will give different measures. The same investigator, but he give different results. This is called intra-observer variation. Or sometimes there are inter-observers between different observers. Investigator 1 and investigator A, investigator B, they will give different measures. This may be because of different personalities, different training practice, or sometimes have visual acuity problem or digital preferences in measuring in quantitative measurement, for example, of the hemoglobin, of the blood sugar, of the blood pressure. So some people, they prefer to have absolute number without taking in consideration the digital the digits. For example, some people prefer to measure the hemoglobin as 11 milligram, or some people they measure 11.4, 11.9. So there are preference of digits. Also for the blood pressure, some prefer to have absolute number 130/80, but others, for example, prefer to have 130.5 over 180.3, for example. So but some people, they prefer to have absolute number, and some people prefer to have digits. The variation in the methods or in the techniques, and this is a result either from, for example, you are measuring the blood pressure while the position, as we mentioned, the at sitting position or lying position, or the cutoff point. As we mentioned, some people, for example, prefer special cutoff point. So always in the measurement, we should have an international level or cutoff point in order to see whether to say that this individual is normal or abnormal. The apparatus itself, the apparatus which we are going to measure, it should be in a good condition and the same type and the same instrument for all the sample. Recording. So it is also important to when we are recording, it is whether by typing or by coding. So coding, it means that put codes for different measurements. For example, sometimes when we are recording for sex, either we put 1 and 2, 1 for male, 2 for females. So sometimes there will be inaccurate recording, or for example, for education, 1 you are going to put codes 1, 2, 3, 4. One, for example, for high academic attainment, or illiterate, or moderate education. So you are going to give 1, 2, 3, and this is called codes in the recording. Interpretation of the results. As we mentioned, it is important to have a certain cutoff point for measuring in the same using the same measurement or the same cutoff point for all the people. There is another method, or which is called Hawthorne bias. Individuals who are aware of being participant of the study behave differently. Some people, when they know that they are going to participate in certain study and know the effect of this study, or the association of the study of between the exposure and the outcome, and they will try to behave in a different way. So, regarding the selection bias, we mentioned that one source of the bias is the selection bias. So, selection bias occurs when there is systematic difference between the characteristic of the people selected for the study and the characteristics of the people who are not selected. So, sometimes an obvious source of selection bias occurs when participants select themselves for the study, either because they are unwell or because they are particularly worried about an exposure. Some people, they want to participate in the study because they feel that they are unwell and they want to participate and to know what is the effect of the exposure on the outcome. Or sometimes, if there is a well-known, for example, the people who respond to an invitation to participate in a study on the effect of smoking differ from that the smoking habit when among those who are not responding. So sometimes when you invite some people to be involved, if you want to study the association between smoking and lung problem, so or other diseases, so some people who respond to your invitation may have a different exposure than those who are not respond. So this will result in overestimation of the result. Or if the people who do not respond, they may have heavier heavy smoking habit, and this will lead to underestimation. So, in studies of, for example, and another selection bias result from the study on children health, because we are going to take the information from the parents, and this this will be affected by the cooperation of the parent in giving the information. Also, individuals entering or remaining in the study have different characteristics from those who are not selected initially, or who drop out from the result. So this will result in underestimation of the estimation of the exposure and the outcome, the association between the exposure and the outcome. So if the people who are selected or who are drop out, they have high exposure, but because they are drop out, so this will lead to underestimation. An important also selection bias is introduced when the disease or factor under investigation itself makes people unavailable for the study. Sometimes, for example, when we study the effect of certain occupation on the health of the people. So when we investigate or when we choose some worker, they may be absent at the time of the selection because they have exposed and they have the result of the exposure, and they are absent because they have the disease, or because they are they were unavailable because they are absent because of the effect of exposure. For example, if we want to study the effect of the formaldehyde on the eye irritation, so when we choose some people where they are available at the time of the study, we will have underestimate those who are absent at that time because they left the occupation or they were absent because of the disease. So this will lead to underestimation. This will lead to misleading result, or this will call the healthy worker effect. We are going to take the healthy worker because they are not affected by the exposure, and we underestimated, or we didn't choose that worker because they are absent from their occupation because of they have the effect of the disease. So this will lead to or sometimes they are excluded from the employment because they are absent. So similarly, if a study is based on examinations done in a health center, or if we choose our sample from the health center, we are going to choose the people who are ill or severely ill. And because they consult the health center because they have highly exposed, or they have the effect from the exposure. So they are not representative for the actual situation. This is result in selection bias. The hospital admission rate bias. In the case control study, if we choose the cases from the hospital, the cases they tend to they represent the severe cases. So this will result in the bias selection because we are going to select they are admitted to the hospital and they have disease because they have a high exposure to the risk factor, and they develop the disease because of high exposure. So this will lead to overestimation of the association between the risk factor and the disease. Exclusion bias. If different exclusion or inclusion criteria are used in different study group, it is important when we select our sample, we put inclusion criteria and exclusion criteria. So they will, by this exclusion criteria or inclusion criteria, we will reduce the selection bias. So an example, if the inclusion from the control but not from the cases of the of persons with a specific previous exposure or characteristics. So it is important to exclude and include criteria between the control. Use the same inclusion criteria or exclusion criteria we used for the cases and for the control. This will decrease the risk of selection criteria, selection bias. So this will lead to under representation of this exposure among the control and among cases. Information bias. Another source of the bias is the information which is drawn from the individual. It should be obvious that if the information from a study is incorrectly gathered, so the conclusion from the study might be wrong. So there are various kind of information bias. So it is important to take in consideration how are you going to take the information, and this will decrease the risk of bias. One of the information bias is the misclassification bias. Misclassifying exposure or the outcome status is not good thing. Suppose investigators conclude a prospective cohort study with 4 groups of subjects: those who have exercised vigorously, or moderate exercise, or minimum exercise, or not at all. So if we want to study the effect of physical activity or physical exercise on the occurrence of coronary heart disease. So it is important to have a proper categorization of the exposure, whether they have. So it is important to have definition for those who have vigorous exercise. For example, individuals who have exercise every day for half hour or 1 hour every day. This is called vigorous exercise, for example, or moderate exercise if the individual have, for example, half an hour 3 days, for example, or minimum exercise if they have half an hour every week, for example, or not at all exercise. So it is important to define the exposure by appropriate definition of each category in order to have a proper definition of exposure. Such grouping might based on either questionnaire. Sometimes when we collect information either by questionnaires, which is completed by subjects, or by interviewer, either by interviewing or by sending a questionnaire or by calling individual. So the method of interviewing also it should be constant. So if these methods lead to misclassification of exposure status, so bias may result and introduced in our study. So the outcomes can also be misclassified. For example, sometimes incorrectly concluding that some subjects had myocardial infarction when they did not, but they don't. And this can lead to a bias. So, how much bias depends on the type of misclassification. There is another information bias, which is the recall bias. Recall bias: how much the individual have a good memory in recalling the information. For example, in the case control study, we are relying on retrospective exposure. We are depending on the memory or the recall of the individual. So how they are good in recalling the exposure. For example, if we want to study the risk of contraceptive use and breast cancer, so some women, they cannot recall how many years they use the contraceptive, or how many years they use, and how many, and whether they use the contraceptive continuously or interrupted use of contraceptive. So this will depend on the memory of the women. So also, always the notion is that because subjects are aware, sometimes when they are aware of their health status as cases or as control, so such knowledge might lead to differential recall of the exposure. For example, if we take information from individuals and they know that they are cases or that they are controls, so this will affect the exaggeration sometimes or underestimation of the exposure, and this will result in bias. Thus, a certain piece of information, such as potentially relevant exposure, may be recalled by cases but forgotten by control. Sometimes, if we are taking cases of breast cancer and they know that they are cases, and we are asking about contraception, sometimes they try to exaggerate the number of years, for example, or the dose of the contraceptive they are taking rather than the control. So, individuals who are experience a disease, for example, breast cancer or other adverse health outcome, tend to think about the possible causes, and sometimes they try to remember more than those who are the controls. Reporting bias, which is another form of information bias. Sometimes, for certain reasons, especially for social issue or social desirability or social stigma, some people they don't want to report some history, for example, about smoking, about alcohol drinking, or about sexual contact with other people. So they are, because they are aware about the social stigma, they don't report some information about drinking alcohol or for example or social sexual contact with others. So some researcher gather baseline characteristic data. Subjects may underestimate the amount of alcohol drinking or cigarette drinking or drug abuse or sexual contact with others because of the social stigma. They underreport this information, and this will result in what is called reporting bias. Interviewer bias, the individual or the investigator bias. This occurs when data collection methods differ between different investigators. So it is important when we are going to collect information, we have the same questionnaire and we train investigators about the method of collecting the information or measuring the measuring different criteria, and it should be a standard criteria. So in case control study, for example, an interviewer might ask more inquiring questions on cases rather than control, and such inquiring could lead to overestimation or underestimation of the true exposure. So it is important to have a standard method of interviewing or measuring among the cases and the control to reduce the interviewer bias. Another information bias is the loss to follow up bias, especially in a longitudinal study or in a cohort, a prospective study, when we are going to follow up people. Some people, they are lost from follow up. So this may lead to over or underestimation. If we lose follow up from people who are highly exposed, so the result will be underestimation of the association. Or when we lose among people who have less exposure, this will lead to overestimation. So it is important to have a proper follow up and trying to decrease the loss of the follow up. Suppose in a randomized control trial of two groups, group A and group B, followed on the out to study the association between certain exposure and the myocardial infarction. If we suppose that group A, we lose 30% of subjects assigned in group A are lost to follow up, while 10% of subjects assigned to group B are lost to follow up. So, subject assigned to group A might be lost to follow up because they develop warning symptoms of myocardial infarction, such as unstable angina, and therefore they left the study to seek treatment elsewhere. So, if this occur in group A is left with the subjects for analysis. So the subject who are less likely to develop myocardial infarction than those who left in the study. So the subjects remaining in group A are are for analysis are therefore not representative. So it is important to try always to decrease the loss to follow up, because those who lost follow up may be either they have higher exposure and they leave the follow up, or they when we lose when we lost other group who are they have less exposure, so this will lead to either to overestimation or will have underestimation. So it is important to decrease the loss to follow up. The measurement bias, there are their measurement bias occur when individual measurements of a classification of the disease or exposure are inaccurate. And this could be either due to the individual variation or the observer variation. So there are many sources of measurement bias and their effect are of varying importance. For instance, biochemical or physiological measurements are never completely accurate, and different laboratories often produce different results of the same specimen. For sometimes when you go to have hemoglobin measurements in different laboratories, they will give you different measurements. So, if the specimens from exposed and control groups are analyzed randomly by different laboratories, there is less chance for systematic measurement bias than in the situation where all specimens from the exposed group are analyzed in one laboratory, and all those those from the control groups are analyzed in another. So it is important to decrease the chance of systematic measurement by having measurement at different laboratories for controls and for cases. So this will decrease the measurement bias. A form of measurement bias of a particular importance in retrospective case control studies is known as recall bias, which we have already mentioned. This occurs when there is differential recall of information by cases and control, and this will lead to also recall bias of the exposure. So, recall bias can either exaggerate the degree of the effect associated with the exposure, as with the people affected by heart disease being more likely to admit a past lack of exercise, or underestimate if cases are more likely than controls to deny past exposure. If measurement bias occurs equally in the groups being compared among cases and control, so the result is underestimate of the true strength of relationship. Such non-differential bias may account for apparent discrepancies and the result of different epidemiological studies. If the investigator in the laboratory or the laboratory technician or the participant knows the exposure status, this knowledge can influence measurements and cause observer bias. To avoid this bias, the measurements can be made in a blind or double blind fashion. A blind study means that investigators do not know how participants are classified. So if the investigator or the individual who measures make the measurement, they don't know whether the participant they are cases or controls. So this is called blind measures or blind control, or the double blind study that both the investigator and the cases they don't know what the classification, they don't know whether they are the cases and the how they are classified. So how to control for bias? It is important to control for bias or to decrease as much as we can the systematic error. This is either by purposeful in the study design to minimize the chance for bias. Example, use more than one control. So from the design, we can decrease the bias by having more than or increase the number of control group. Also by the design by a clear definition of the study population, also by explicit cases and control and the exposure definition of the exposure among the cases and the control. Also, it is important to define priorly who are the cases and what constitute the exposure in order so that there is no overlap in the case control. For example, cases and controls from the same population. Same possibility of the exposure for the cohort selection of exposed or non-exposed. It is important to define properly, priorly, what are the exposure and what are the cases and what are the controls. Set up strict guidelines for data collection. Train observers or interviewers or the investigator to obtain data in the same fashion, the same method in the collection of the information. Also, random allocation of observers or the interviewers data collection assignment. Use multiple sources of information rather than one source. Also, institutes masking process is appropriate by single blind study or double blind study or triple blind study. Build in methods to minimize loss to follow up and standardized method for the institution or the instrument, sorry. Another important source of inaccuracy is the presence of the confounding variable or the confounding results. The confounding is another major issue in epidemiological studies. In a study of the association, for example, between a case or the risk factor and the occurrence of the disease. Confounding can occur when another exposure exists in the study population and is associated both with the disease and the exposure. For example, if we want to study the effect of coffee drinking and ischemic heart disease, and we have to take in consideration, and we have to take in consideration the presence of other factors which may affect the occurrence of the disease, such as smoking, for example. So if we didn't take in consideration smoking, so this will result in the result what is called the confounding effect, and we reach to an accurate conclusion by just saying that coffee drinking affect the occurrence of myocardial infarction. So a problem arises if this external factor itself determine or risk factor for the health outcome and is unequally distributed between exposure group. So confoundings occur when the effects of two exposures or risk factors have not been separated, and the analysis concludes that the effect is due to one variable rather than the other. So to be confounding factor, two conditions must be met. Confounding arises because non-random distribution of the risk factor in the source population also occur in the study population, thus providing misleading estimate or effect. In this sense, it might appear to be a bias, but in fact it does not result from systematic error in the design. So, for example, the age and social class are often confounders in epidemiological studies. Always they are the age. It is regarded as a confounding factor, or the social class also. It should be taken in consideration in the assessment of the exposure on the outcome. An association between high blood pressure and coronary heart disease, for example. It represents concomitant changes in the two variables that occur with increasing age. So the potential confounding effect of age has to be considered in the occurrence of the blood pressure or the increased risk of coronary heart disease. So another example is the confounding factor may be the explanation for the relationship to demonstrate the coffee drinking and the risk of coronary heart disease, since it is known that coffee consumption is associated always with the smoking use. all people who consume coffee, always they are heavy smoker. So it is important to take in consideration coffee drinking and the smoking. They are always associated together, because so the smoking regarded as confounding factor on the effect of coffee on heart on coronary heart disease. So it is also well known that cigarette smoking is a cause of coronary heart disease. So it is thus possible that the relationship between coffee drinking and coronary heart disease merely reflects the non-causal association of tobacco use and heart disease. In this situation, smoking confounds the apparent relationship between coffee consumption and coronary heart disease. So it is important to take in consideration the association between coffee consumption and smoking on the occurrence of heart disease. So confounding can elevate or reduce or reverse the observed association. So the difference between bias and confounding is that bias creates an association that is not true, but confounding describes an association that is true but potentially misleading. For example, if we want to study the association between birth order and the occurrence or the incidence of Down syndrome, sometimes in certain study they mention that the incidence of Down syndrome is higher among the individual who have birth order. So the individual he born the fifth in his family, the risk of occurrence of Down syndrome is higher than when you are the first birth order in your family. But another study, they found that the association between maternal age and the occurrence of Down syndrome. So, in another study, the higher the age of the mother, the higher is the incidence of Down syndrome. So, if a woman is 40 when she is a preemie, so there will be high risk of occurrence of Down syndrome. So the effect of mother age is more than the effect of the birth order in the occurrence of Down syndrome. So if we take in consideration the maternal age and the occurrence of Down syndrome and the birth order, so we can see so we can see the effect in and if we put both both factor in the occurrence of the occurrence of the disease of the Down syndrome, we can see. So if we put the two factors in the same study, or we take in the consideration, we can see that when maternal age is higher at 40, and it can give birth to even at the first baby, it can lead to Down syndrome. So the effect of maternal age is more than the effect of birth order in the occurrence of the Down syndrome. So it is important to control for the confounding factor by several methods, either also during the design or the analysis of the result. So the methods commonly used to control confounding during the design of the study is either by randomization or restriction or matching, while during the analysis stage is by the stratification or by the statistical modeling. So randomization in experimental studies, randomization is the ideal method for ensuring the potential confounding variables are equally distributed among the group being compared. So the sample size have to be sufficiently large enough to avoid the random misdistribution of such variable. So randomization avoids the association between potentially confounding variable and the exposure that is being considered. Also, the restriction. One way to control for confounding is to limit the study to people who have particular characteristics. For example, in the study of the effect of the coffee on coronary heart disease, so the participation in the study could be restricted to non-smokers, thus removing the effect of smoking on as a confounding factor on the occurrence of the disease. And thank you.